good. Well, I'm excited to present to you all today. So I'm going to be talking about current issues in affirmative practice with gender and sexual minorities. Just as some background about me, of course, I know you all a little bit, or most of you all a little bit, so you already have some of this context, but I'm a health disparities researcher with a particular focus on gender and sexual minority folks. And in addition to that, I identify as a queer woman, and I've been engaged in LGBTQ advocacy for at least 15 years. So it's an issue that's near and dear to my heart. So I'm always excited to talk about it. So I will say that this is an incredibly broad topic, and so I tried to grab some of the best hits to talk about today and to present to everybody today. But I recognize that in doing so, I might be sacrificing a little bit of depth for the sake of breadth. So please do send me questions or stop me if you want to go a little bit more in depth to any of this information. I'm more than happy to do that. I was telling Julie before you all came on, I think one of the complications of this kind of presentation is that I think people have different levels of familiarity and comfort with talking about gender and sexual minority folks and their experiences. And so I'm trying to tailor this presentation to make sure that we're all kind of on the same page, but also hoping to bring in some of your own experiences or expertise so we can talk about maybe affirmative practices that have worked for you as well. Okay. So just to give you all a sense of what I wanted to talk about today. So I thought I would start with some more foundational terms and conversations about gender and sexual minority experiences. Again, this might be very much kind of familiar area for some of you, but again, I think it's helpful to review some of this language. I think some of the microaggressions that we hear about that can occur in the therapy session are sometimes just around outdated language or language that maybe isn't quite hitting the mark for that individual or really helping that individual feel validated. So sometimes I like to start here again to make sure that we're all kind of using the same kind of language or hearing about maybe what other language I might be missing, because as I mentioned, so I identify as a sexual minority, I don't identify as a gender minority, and so I recognize that we might be bringing in our own experiences and connections to this work. So I invite you to talk about that as well and correct me if maybe I'm using a term that isn't maybe the best term to be using at this point in time. I think that's one of the reasons that I also start here is I think terminology and the way we talk about things in gender and sexual minority spaces can change a lot over the years. And so I recognize that sometimes even my language is not up to date. Then I wanted to talk a little bit more about considerations for care delivery. So thinking a little bit about the health disparities that we're seeing, some of the barriers to care that we see among individuals who are gender and sexual minorities. Then having a conversation about resilience and how we can help our clients build resilience in a world that isn't always maybe accepting or tolerant of their experiences. And then this is me being really optimistic. I also have some case examples that we can get to, but we might not make it there today, but I'm going to try. So before I even launch into my conversation about kind of these foundational ideas for thinking about gender and sexual minority experiences, I thought it would be helpful to just mention why I use the term gender and sexual minority identities. A lot of people, and sometimes you'll hear me using the term LGBTQ or LGBTQ+, or sometimes I'll say queer and trans. But I like to use gender and sexual minority identity or gender and sexual minorities as the term here because I like how inclusive this is. I think the con is that it tends to be more academic. You're not necessarily going to hear this in a ton of LGBTQ spaces in the day-to-day. But it doesn't maybe prioritize some experiences over the others that can kind of help it happen with that term LGBTQ. So there's a lot of politics that goes into whose identities get represented in the acronym and whose gets tagged into that plus at the end. So that's the reason you'll hear me using this term gender and sexual minorities today. Okay. So starting with these foundational ideas and talking a little bit about language around identities, I thought it would be helpful to start here talking about kind of the gender spectrum. So this resource, if you're familiar with it, it's a great one. It's adapted from something called the Genderbread Person. There have been a few iterations of this. There's also this gender unicorn, but it's essentially a teaching tool to talk a little bit about the differences in terms of elements of gender and elements of attraction. And I think it does it in a really nice visual way. So I thought I'd start here talking about the gender spectrum. One of the reasons I like this resource, you'll see up here on the screen, is that we have this dual, I'm not sure if you can see this laser pointer, but we have this dual continuum approach to each of these areas. Sometimes when we conceptualize gender, we conceptualize it as existing on two polar ends of a spectrum. So men are opposite from women. And this resource really thinks about the ways in which we can encompass aspects of masculinity and aspects of femininity. So that's one of the reasons that I chose it. So it starts off with gender identity. So this is essentially that inherent deep sense of self that people have about gender. And so here we see that someone can identify high on this womanness scale or high on this manness scale. And for people who don't identify maybe more towards this womanness or more towards this manness, we might see people identifying using terms like gender non-binary or gender queer. There's an array of other terms that'll come up today too that I'm happy to talk more about. So gender expression talks a little bit about the ways in which we kind of display our gender to the world and how we depict that. So this is kind of our feminine presentations or masculine presentations. And here again, people can encapsulate varying amounts really at any given time of femininity or masculinity. So again, this is kind of maybe complicating the conversations we might have around gender expression. And then this last piece uses the term biological sex. I think generally speaking, the term that tends to be agreed upon in more regularity is the term assigned sex at birth or sex assigned at birth. So this refers to the ways in which someone's reproductive organs were classified as male or female when they were born. And so here too, we see variability that often kind of isn't brought up in our conversations around gender, but individuals can be born with a variety of intersex conditions. So both their internal and or their external reproductive organs don't fit our ideas of what is male versus what is female reproductive organs. And so intersex individuals are often assigned a gender at birth, and there's a growing push in intersex communities to hold off on any surgeries until an individual can decide for themselves what they want to do with their own bodies. But we see historically that wasn't the case. Children born intersex were often operated on. Notably, not everyone knows that they're intersex at birth because, of course, a lot of reproductive organs are internal, and they might find out later in life. So when I'm using the term transgender, I'm talking about an individual whose sex assigned at birth maybe doesn't match up with their gender identity. And when I'm talking about a cisgender individual, I'm talking about a person whose assigned sex at birth does match up with their gender identity. So for example, I was assigned female, I identify as a woman, I'm a cisgender woman. I will say, just kind of a note on terminology, I think in a lot of the literature on transgender experiences, you'll see a lot of discussion using terms FTM or F2M and M2F. meaning female to male or male to female. This is a term I still hear used a lot, but I think there's a growing sense that using terms like transmasculine and transfeminine tend to be preferred terms here because the prior, saying female to male, really misses the fact that this person maybe never identified as female. And so transmasculine might capture that experience in a way that's a bit more validating. I'm wondering so far if there's any questions about terminology here, or if anyone thinks that there's something that should be added. Okay. Okay. So then I thought I would jump to this other piece about thinking about sexual orientation. So one of my shticks is that sexual orientation is a bit of a misnomer. So we can really break down attraction into sexual attraction and romantic attraction. So a lot of times these overlap, but not always. And I think what's particularly useful about breaking down these concepts into sexual attraction and romantic attraction is recognizing that people can be at varying, can have varying extents of motivation to engage in sexual relationships or romantic relationships. So here we're talking about, kind of looking at this, we're talking about individuals who are sexually attracted to men, women, non-binary folks in between, right? Or who might not experience that much sexual attraction towards others. That doesn't mean that they necessarily don't want to be in relationships. And it might not even necessarily mean that they don't want to engage in sex if they're in a relationship. Now here I'm talking about asexuality. So this, I think, is sometimes confused, and one of the common microaggressions that asexual people experience is having their identity being conflated with a trauma response. So of course people might not want to engage in sex after experiencing a trauma, but when we're talking about asexuality, we're talking about people who just aren't maybe super motivated to engage in sex. And it might not even be that they really don't, that it's disgusting. It might just be that they'd rather be doing something else with their time. Or it could be that it's really aversive to them. Similarly, with romantic attraction, there are individuals who identify as aromantic, or sometimes shortened to aro. And so these are individuals who might want to engage in sexual relationships, but don't necessarily want to engage in kind of lasting romantic relationships. And again, I think that this is helpful to differentiate asexuality and being aromantic from being queer. So someone can be asexual and still identify as straight, for example. They can be asexual and identify as queer. So these identities can really kind of stack on top of each other for people. And I think sometimes we talk about it in a way as if it's one or another. And that's frequently not how people identify, though sometimes it may be. You may have also heard me talk about these terms in the survey that I sent out, monosexual and non-monosexual. So here, when I'm talking about monosexual individuals, I'm talking about individuals who are attracted to one gender. So this includes people who identify as heterosexual or straight. It includes individuals who identify as lesbian or gay. And when I'm saying non-monosexual, I'm talking about individuals who might identify as bisexual, pansexual, omnisexual. So they're attracted to more than one gender, is essentially what I'm referring to there. Any questions about those pieces of terminology or things to add or corrections? Okay, great. I just thought I'd check in. So again, I think that this is a helpful place to start, to be giving us language to talk about these experiences. And I also recognize that many of us may have these experiences. And so I also want to make space for that. I do think that a helpful activity when we're thinking about any marginalized group is thinking about experiences that individuals in those groups might have that we might not be aware of because they don't come up regularly in our lives. So I thought I would take a second here to go through some experiences of privilege that people who might be cisgender and heterosexual might not be aware of in terms of experiences of marginalization that gender and sexual minorities might have. So this is done very much in the style of Peggy McIntosh's white privilege, male privilege. So in these pieces, she talks about some common aspects of privilege of being white or being male that people might not be thinking about in their day-to-day lives. And since that point, this exercise has been adapted to other marginalized populations, including gender and sexual minority folks. So I thought I would go through some of these just so we can begin to think about which of these are on our minds and which of them are not, and what might that mean or what might that bring up in our working relationships with our gender and sexual minority clients. So I'll just read them off. So the first one I have is I can express affection in most social situations and not expect hostile reactions or harassment from others. I can use public restrooms without fear of verbal abuse, physical intimidation, or arrest. I can be confident that my parents and family will talk openly and honestly about me and my partner with their friends and coworkers. I can use public facilities such as gym locker rooms and store changing rooms without stares, fear, or anxiety. If I end up in the emergency room, I don't have to worry that my gender will keep me from receiving appropriate treatment or that all of my medical issues will be seen as a result of my gender. I can expect that others will use my accurate pronouns without having them act like they're doing me a favor. I can have a picture of me and my family in my office without worrying how it will impact my relationships with my clients. I can purchase clothes and shoes that fit my gender expression without having to custom order them. I don't worry about how I'll explain society's discomfort with my sexual orientation or gender identity to my children. I can flirt, engage in courtship, or form a relationship and not fear that my body status may be a cause for rejection or even an attack, nor will it cause my partner to question their sexual orientation. If I can choose a restaurant or bar to visit without worrying whether or not there's a bathroom I can use if needed. I can reasonably assume that my ability to acquire a job, rent an apartment, or secure a loan will not be denied on the basis of my gender or sexual orientation. And I can plan a vacation or business trip without worrying that people like me will be unwelcomed or outlawed in that place. So that's a list of some of those privileges or experiences that might not be on the forefront of our minds, or they might be, that people who are gender and sexual minorities may be experiencing in their day-to-day lives. It's not an exhaustive list, of course, but I think it's a good place to start to be recognizing or starting to think about what are the experiences that might not be in my awareness that might be having a profound impact on my client, or even just adding to that incremental stress that they're dealing with from day to day. Okay. This wasn't the smoothest transition. I was going to make it a really good one, but I lost it. But I did also, when thinking about the experiences of gender and sexual minorities, I also wanted to really try to hone in on some of the experiences of gender and sexual minorities in Maine in particular. So of course I'm new to Maine, so this is based on what I've heard from others. This is based on what I've found in my research. But I thought I'd talk about at least some of the laws and how the state's doing in terms of protecting the rights of gender and sexual minorities. So to start, a recent survey from the Williams Institute found that about 5% of the Maine population identifies as a gender or sexual minority. And what we see is that Maine is doing a great job with its non-discrimination ordinances. I was very happy to move here. So gender and sexual minority Mainers are legally fully protected under non-discrimination ordinances and things like hiring and things like searching for apartments and seeking a loan. Of course, whenever we see non-discrimination ordinances, I think it's important to recognize that their existence doesn't always equate to their enactment, and that it's difficult to maybe consistently enact these kinds of ordinances, but at least legally they're there, and the state is doing, it sounds like a good job thinking about how to ensure their enactment. Some of the unique considerations for gender and sexual minority Mainers include there's a larger population of older adults who are gender and sexual minorities in the state of Maine. Of course, Maine has a larger aging population than many other states. And Maine also has a large rural population. I highlight these in part because what we know is that gender and sexual minority older adults and rural gender and sexual minorities tend to report more of a sense of isolation and disconnection. We're going to be talking a little bit about mental health disparities. And of course, I think when we're thinking about suicide in particular, one of the pieces or one of the major risk factors we might think about is a sense of isolation. And so I think that's important when considering what might be some of the stressors faced uniquely by gender and sexual minority Mainers. In general, as I mentioned, the state does a really good job with its non-discrimination ordinances, by my understanding, as someone, again, who's recently moved here. But there are still areas for improvement that have been pointed out. So one is that health settings don't systematically collect data on gender and sexual minority identities, which of course can serve a protective role for those individuals if they don't want to report. But this also means that maybe we're not always capturing what are the unique health needs of gender and sexual minorities in Maine. We also see that not all state employees have access to health coverage that might include gender-affirming medical interventions. So that's a little bit inconsistent across the state. And then Maine has recently, you might be more aware of this than I was, has recently changed some of their documentation protocols. So it used to be that transgender folks in Maine who wanted to change their gender marker on their ID had to have a letter confirming their gender from a healthcare provider. And recently this was overturned, which is great. One of the few hangups that sounds like it still persists is publication requirements for name changes. So most states require you to publish that you've changed your name if it's not due to something like a marriage. Maine is no exception, although there is a bit of an asterisk here, so you can petition to not have to publish your name change. So that's a good thing to know if you have a client who's going through this process, to ask to be able to petition to not publish it if they don't want, because of course that can pose kind of a safety risk for individuals. Okay. So that was a little bit of my background, and now I wanted to turn our attention to think a little bit more about care delivery and the mental health system, and maybe have a couple of conversations. So thank you for sticking with me so far. So I think that this information is disseminated relatively well, some of the mental health disparities that we might see among gender and sexual minorities, but I still think that it's helpful to outline them here. So we know that gender and sexual minority individuals are 2 to 3 times more likely to be diagnosed with a variety of mental illness experiences, including depression and anxiety and substance use disorders. And when we look at the research, we see in particular that bisexual and transgender individuals are at the highest risk for kind of elevated mental health concerns. So here we might be thinking about additional marginalizing forces, such as higher rates of violence experienced by these populations, and not always being accepted in LGBTQ spaces. And what we know based on the literature is that these elevations in risk for mental illness and for psychological distress can, in part at least, be explained by experiences of minority stress. So I'm talking about past experiences of discrimination, microaggressions, things like fear of rejection or real rejection that people have experienced. In light of this, I think it's also important to talk about suicide risk. This is one of the prominent disparities that we see among individuals who are gender and sexual minorities. So sexual minorities, based on the research we have, attempt suicide at 2 times the rate of the general population. There are notably high rates of suicide attempts amongst individuals who are transgender. So there's some variability in the research, but generally speaking, our research supports this idea that around 1/3 to about 45% of trans individuals have attempted suicide throughout their lifetime. And at least sexual minority adolescents report attempting suicide at 4 times the rate of heterosexual adolescents. And so I think there's a lot of urgency for us to be thinking about how do we make our practices as affirmative and accessible as possible for, of course, a variety of populations, but here speaking specifically about gender and sexual minority folks. So I think it's helpful when we think about, well, maybe I'll back up for a second. So if we look at the research, there's some research to suggest that gender and sexual minority individuals seek out mental health services at higher rates than the general population. And they report a disproportionate number of barriers to care and barriers to affirmative service. So I think it's important when we contextualize this in particular to think about the history of the mental health field's treatment of gender and sexual minority folks. I think about this a lot because I feel that most of the spaces I've been in have been spaces that really prioritize providing affirmative care to gender and sexual minority clients. And I think it's important to not forget that the history of the field is one that was pathologizing of gender and sexual minority identities, and many might argue continues to pathologize the experiences of gender minority folks. And we can understand where this can pose a real barrier for individuals seeking care who are worried that their identities and experiences might be conflated with mental illness rather than being understood through something like minority stress experiences. What we also see is that gender and sexual minority folks avoid or delay mental health care, so report regularly doing this for fear of experiencing discrimination or microaggressions in the care setting. And when gender and sexual minority folks do seek out mental health care, finding affirmative treatment can be really difficult. I don't know if you've ever done this, searching for gender and sexual minority affirmative providers in Maine, or even going on Psychology Today and clicking the LGBT button on the side. You know, the results you get are a bit of a mixed bag, especially on Psychology Today. It's hard to determine, does this person identify as a sexual or gender minority, or is this a population that they've received extra training in or that they're passionate about? And so finding services where you know that you're going to be affirmed and validated isn't always a straightforward process. And what we see is that individuals do report experiences of discrimination and microaggressions when seeking out mental health services, and may or may not always actually report these in the therapeutic setting. And we see this potentially with the potential to being linked with kind of poor retention and treatment. So I thought I would bring up a few common microaggressions that we hear about in the literature, and just some issues that might come up in the clinical setting that people report on. So one of the most commonly cited microaggressions that people experience when seeking out mental health care is mistakes with pronouns or being misgendered. So I think that this is a common struggle for individuals who, especially who might use things like they, them pronouns. But I hear this a lot from providers too, that they might slip up and they don't really know what to do if they've slipped up and they've used the wrong pronoun for someone. And so this is kind of my own advice, but I also think echoed by individuals within gender and sexual minority communities. And that's if you do slip up and use the wrong pronoun, correct yourself and move on. So what we sometimes see individuals doing is they might use the wrong pronoun and they'll be extremely apologetic, and then it becomes kind of weird and you feel like you have to tell them it's okay that they messed up your pronoun, which is also kind of a weird interaction. So you end up kind of almost apologizing to the person who misgendered you. And so one of my go-to responses, if you're struggling with pronouns, just correct and move on if you do make a mistake. And also practice can be really helpful. So actually practicing using a person's pronouns can be useful to doing it when they're around. Of course, practice makes perfect with everything else in life, same with pronouns. I will say one of the things that I hear a lot too is the term preferred pronouns. Ideally, we would say just pronouns, right? Because it's not a preference for the individual. So we might say pronouns, we might say accurate pronouns. One helpful thing that we can do that I didn't do today is introducing our own pronouns in interactions can be a helpful way to set the stage for recognizing that people use different pronouns. Some things that groups may do is asking people their pronouns at the beginning of group, although there's some contention about asking people to name their pronouns, especially in this kind of public space, that being that sometimes people just don't want to talk to other people about it. So that's why I like the strategy of offering your own, and if other people want to talk about their pronouns, I can give them space to do so. Another common issue that comes up is simply infrastructure. So we know that, for example, having bathrooms or rooms or beds for individuals who are seeking mental health services can be an issue. Some individuals will spend a lot of time trying to figure out if there's a bathroom wherever they're trying to seek services. And sometimes, of course, I think this is more of a systemic issue, thinking about how can we make accessible bathrooms, or how can we make bathrooms accessible? Do we have that space? And there are a lot of conversations about how to do this. One of the other things to think about is if we're ever kind of suggesting a higher level of care for individuals who are gender minorities. A lot of inpatient settings don't have plans for gender minority folks in terms of rooming situations or bed situations, and recognizing that this can be a struggle for individuals. There's also this gatekeeping role that we can play as providers. So a lot of gender affirming medical interventions, a lot of providers who do these surgeries still require letters of support from a mental health provider. And so you may have been in a position where you have to provide these. And so recognizing kind of the inherent power dynamics that occur when we are in this gatekeeping role that can come up in therapy. Another common microaggression I hear about is body policing, at least making assumptions or making statements about whether or not someone passes, or assuming that someone wants to quote unquote pass, which in and of itself can be kind of a derogatory term in the sense that people express themselves how they express themselves, and who decides what passing means, and what it means to look like a woman or to look like a man. And a lot of, it's not uncommon for providers to ask really invasive questions about body anatomy or progress with surgeries or hormones or things like that, when maybe it's not something that the consumer really wants to be talking about. We also see a lot of examples of essentially non-monosexual erasure, so assuming someone's sexual orientation based on the relationship they're in, rather than actually asking them about their sexual orientation. And also something that I've been hearing increasingly, which this isn't one that I pulled from the literature, but I've had conversations about to think about, is responses to sociopolitical events. I think sometimes individuals might report real fear that they're experiencing in response to sociopolitical events and changes. And sometimes providers might be in the situation to downplay that fear or try to help them cope with the fear, rather than recognizing that this is something to be afraid of. This is reasonable fear to have. So something to be thinking about in our interactions with our clients. Okay, that was a lot of me timing, or a lot of me talking, and maybe I didn't have the best timing on it. So I'm looking at the time now, realizing that. But I thought it would be nice to maybe have a chance to answer this question about what we've done or what we would hope to do to improve our own affirmative practices with our clients. So I thought this could be a great chance for us to maybe use the breakout room tool and take a couple of minutes to talk about this idea of what we've done to make sure our therapeutic space is an affirmative one, and then maybe come back together and talk about some of the highlights.
Gabby and I were kind of talking about similarities we had noticed in terms of transitioning from working in college counseling centers to private practice. And I don't know, just noticing maybe that among younger people, like talking about pronouns and identities is more something they might talk about like right off the bat. But that with older clientele and older populations, just the wider spectrum we see at PSM, like it doesn't always come up right away. And so maybe like more asking specifically in like an intake would be helpful.
Definitely. Right. And considerations too. I'm wondering about considerations with language and the way we talk about things. Thinking even around things in the ways that we might describe gender and sexual minorities, using terms like queer versus terms like lesbian or gay.
Yeah.
I guess your question implied like, what are we doing proactively? And it makes me want to look at our intake paperwork to see if there's anything else we could do just from that very first impression of how we're being inclusive and terminology. So that might be something I revisit and get some feedback on from all of you.
Right, that's one of the first points of contacts for which someone might be basing. Is this a space where I'm going to be safe, or maybe not?
Yeah.
You know, I was wondering even on intake information about bathrooms, is that brought up? You know, to even discuss that with people in your building?
I think that's really great. I know I spend a good chunk of time or looking up where there are inclusive bathrooms or accessible bathrooms, and when places have it listed, I'm so grateful. Just knowing, even just to plan around my visit, is this a place where I can access a bathroom or not?
And I was also thinking, even asking our landlords, our building owners, like, what have they done to, you know, just being the people that also bring it up.
If you ever have a client who's in this situation where maybe they're struggling to find bathrooms where they're going, or that might be a reason why they're not engaging in meaningful activities, there's an app, and I can't think of the name of it, but I'll find that and maybe put it on a little bit of a resource sheet.
Okay.
Yeah.
That'd be great.
What would be the preferred, I mean, what's the ideal solution to that, would you say, Hillary, in terms of bathrooms?
In terms of bathrooms. So I've never been to the PSM office, so I can't speak about that too directly.
Well, our building has public restrooms that are genderized, basically on every floor. So not within our suite, but outside of our suite. It's definitely genderized male, female bathrooms throughout the entire building.
So I think that there are a few ways to approach this, and I don't know that there's an ideal solution. And of course, I mean, ideally, you could get the whoever owns the property to change even one of the bathrooms so that it's an all gender restroom, even just one on one floor. Other options that I've seen people do are letting clients use staff bathroom, if that's where they're going to be comfortable, and letting them know that they can ask to use that. And if neither of those are possible, I think being very clear up front that this isn't something that you have accessible and you recognize it's a concern and potentially a barrier for individuals. Just letting them know to plan around it and that it's something that you're aware of, which of course could still be read as, well, you're not doing anything to change it, right? That's what an individual could feel when they look at that. But on the other hand, they could feel like this is something that could be hard to change. And I appreciate at least this is something on your radar.
Yeah.
Yeah. Any other thoughts that came up? I think it's an interesting conversation. So one piece of terminology I like around creating affirmative practice is this idea of knowing when to generalize and knowing when to localize. And what I mean by that is recognizing that sometimes it's helpful to know, okay, gender and sexual minority folks have higher rates of attempting suicide. So maybe this is something that I need to check in with in a certain way. Or maybe I know this might be an experience, maybe this person experienced rejection from their family and maybe I should check in about that. That's just kind of generalizing, but also recognizing that sometimes this might not be salient for the individual or their experience. I can think of a time when I first started clinical practice where I was trying to figure out my own language for how I ask about sexual orientation in the treatment setting. And I asked something like, so I see you're bisexual. How is that? To which the person replied, well, it's fine. I have no problems with it. It's been good. But I think it was kind of a funny conversation because it kind of spoke to, well, first of all, finding our own language to talk about these things can be helpful. But also I think it's helpful to recognize that the things that we talk about that might apply to gender and sexual minority folks based on common experiences might not be the case, of course, for every person who identifies as a gender and or a sexual minority. So there is one last thing I thought I would mention, and I could bring us back to the slides, but I don't need to. But I wanted to touch on this piece of resilience because this was a question I saw coming up a couple of times when I sent out that survey. Is just, we spend so much time talking about the risks experienced by gender and sexual minority folks and kind of the negative experiences that might be more common or this community might be at higher risk for. And we don't spend a lot of time necessarily talking about these elements of resilience to the extent that identifying as a gender and or a sexual minority might feel like, gosh, there's so much weight to this. And when I think about resilience, I think a really helpful way to define resilience comes from Dr. Maston, who is big in the resilience field. She's a developmental psychologist. And she defines resilience as the capacity of a dynamic system to adapt successfully to disturbances that threaten system function, viability, or development. And I like this definition of resilience because it locates resilience within the community. Sometimes when we approach resilience, we talk about it as if it's a trait. And I think, of course, it's important to think about empowerment and how we can empower our clients and help them define resilience for themselves. But I think that if we focus only on what an individual can do to be resilient, we run the risk of making people feel like they've failed at being resilient if they experience negative life outcomes. And so when I think about resilience for gender and sexual minority folks, I often think about it with 4 tiers. One being promoting communities of healing, communities of shared experience, and trying to connect my clients who might want it with community so they don't feel alone. Another piece that I think about is assessing for past experiences of minority stress and how those might be impacting their engagement with care. Seeing if it might be a barrier or there might be some anticipation of rejection or fear about seeking services and thinking about how that might be impacting their time in therapy and what they're getting out of therapy. I think about this in terms of promoting identity pride. So I like to assess whether or not someone's identity is important to them, and similarly, if they're proud of it, because we see that identity pride is correlated with more positive mental health outcomes. And if someone doesn't feel proud, what's happening there? Where's the guilt, or where's the shame? Where's that coming from? And then the last piece that I think is important, that I think we're all kind of demonstrating today, is putting on kind of an advocate practitioner hat and thinking about how we're working to make our community safer for gender and sexual minority folks. Because if we're truly thinking of resilience as a community effort, we're a part of those communities. So with that, I want to thank you all again for letting me talk about this. And I know, again, it was incredibly broad, but I'm always happy to answer questions or point people to resources that might be helpful.